You guys see that all right? Okay, there we go. Now I see it. So today's talk, it's going to be a lot. So I as I was putting this talk together, this is new compared to prior years. I realized I had a lot to say about delirium and the sort of intersection of dementia. I almost wanted to take out the post-COVID discussion just because the research is still kind of fresh and still ongoing. But I figured that was part of what some people joined for. So I still have a couple slides on it. It's going to make sure I'm going to go like 5 minutes long, but I'll stay after because I'm sure there will be some questions with this. So objectives wise, we'll first want to talk about why is delirium important. So I'll kind of highlight a couple reasons why this is such an important topic. We'll have to define it at least as best as we can. And then we'll talk about some of the risk factors for delirium, including that sort of intersection between delirium and dementia, and then review some of the evidence behind delirium prevention, delirium risk reduction, and at least talk about some of those tips. So why should we care about delirium? It's extremely common. It's as common as about 50%. If you kind of look at the different studies, it's a different average, but the average of those studies, somewhere around 50% of folks over age 65 admitted to the hospital will experience at least some amount of delirium. And it's expected to be preventable in at least a good percentage of cases. This also seems to be a risk factor for neurodegenerative diseases like Alzheimer's disease and Lewy body disease. I was trying to think of a good analogy. It's kind of like we think of these cardiac stress tests. This is kind of like a cognitive stress test to the brain when we talk about a delirium episode. And it's also associated with acceleration of cognitive decline. So if patients are in more mild stages of a neurodegenerative disease, they're more likely to progress to dementia faster or through different stages of dementia. And so when we think of a working definition of this, it's a broad topic. There's many different causes of delirium, but the overarching theme is this is a sudden change or an abrupt change in mental state and consciousness. It's usually characterized by some combination of confusion, disorganized thinking, disorientation, hallucinations, changes in attention and focus. These are usually transient conditions with fluctuations in between. And the nature of delirium is that it is reversible. That's partly what helps differentiate it between dementia, although also dementia tends to be more of an insidious, longer onset, right, rather than a sudden, abrupt change. But is there a link between the two? So a couple of papers have addressed this. There's been a really good meta-analysis in JAMA Neurology back in 2020 that looked at 23 different studies and basically found that kind of the average between those studies, the odds ratio was about 2.3 for those that developed dementia versus did not, progressing to dementia. That was associated with a subsequent diagnosis of dementia within the next year. The studies that were done, that were like followed patients longer and that were better characterized, meaning the ones that like had definitions of mild cognitive impairment prior to the admission, those all had higher odds ratios. A study specifically looking at this called the DECIDE study, delirium and cognitive impairment or impact in dementia. Their study found an increased odds ratio of 8.8 of developing dementia within the next 12 months after a delirium episode. And then specifically, the study also looked at number of episodes. So repeated or recurrent delirium really increased that odds ratio. And then the severity of delirium significantly increased the odds ratio as well. There's an intersection here that I think about with Lewy body dementia and delirium. So you can think of what is some of our working definitions of, to help us diagnose Lewy body dementia? Well, it's cognitive fluctuations. That's one of the cardinal features. It's pronounced variations in arousal and alertness. It's attentional and executive dysfunction. It involves visual hallucinations. It involves circadian rhythm disruption. So are these really just kind of a spectrum of the same thing, right? That's a reasonable question to ask. So much so that in 2020, there was a research criteria published for maybe we should at least have a definition of a presentation of dementia with Lewy bodies as delirium onset. So we know that caregivers will report episodes of delirium and marked fluctuations, a year before DLB diagnosis, 43% of the time. Delirium incidence, like at least documented incidence, is much higher in DLB than it is in AD 1 year prior to diagnosis. And then 1 in 4 DLB patients will have repeated delirium episodes before diagnosis. And we need more research to kind of really decide, is this really a separate DLB, a different way it presents, or is this just part of that spectrum of DLB? But there's reasonable pathophysiological links between these two too. So if you look at EEG, which is measuring brain waves between these two disorders, so a brief little overview of brain waves. When we're like actively focused in the focused attentive brain network, problem solving, concentrating, we have very fast up to 40 hertz frequency gamma waves. Beta frequency is slower, alpha frequency more so, and then you see theta and delta down here that are much slower. So they've done post-operative recording for like patients that do not have delirium. Here's an EEG recording at the top where it looks much more like this beta wave activity, kind of what you would expect to see. But in someone that has delirium, you can see there's quite a bit of slowing, more in this theta range, and then bridging a little bit in this delta range for part of it. When we look at Lewy body patients, there's actually a supportive feature on EEG that can help at least support a diagnosis. It's not a indicative biomarker, but a supportive one, where we see a change in the posterior dominant rhythm. We see increased theta wave activity where there should be alpha wave activity. And specifically, when you do like an eyes open and closed test, you see a difference between the DLB patients, where here's healthy controls, where you see a change in the alpha reactivity when you open and close eyes, versus DLB, you get this loss of this alpha reactivity. And this has really been consistent across multiple studies in patients with DLB. We can even see, like in patients that are actively fluctuating, we can see these changes on brainwave tests as well in patients with DLB. And so you can see how this lies a little bit along a similar spectrum of slowed brain waves. There's a really good Nature Reviews neurology article. 2 of the giants in the delirium research field came together to write this. And so it kind of really discusses this interrelationship between delirium and dementia. And you could kind of think of it like someone, and I'll kind of circle back to this concept at the end, but someone that has a vulnerable brain undergoes this cognitive stress test of some sort of illness or other factor, right? If they've got cognitive resilience and things, and obviously if we prevent it, no delirium ensues, right? But when delirium occurs, there's neuroinflammation that happens, and you can get a lot of different pathways of acceleration of underlying pathology resulting in dementia. One thing that I'll bring up, like what is one possible mechanism here? Well, we know that the blood-brain barrier changes with aging. So I use this analogy as I'm kind of explaining to patients, and I think it's a helpful way to think about it. You could think of the astrocytes in your brain kind of like the bouncer of the blood-brain barrier, right? They're kind of the security guard, and they protect club brain, right? As far as the VIP access to this brain. And they're basically protecting it from sort of the riffraff stumbling through the bloodstream, right? All the toxins and viruses and bacteria and neuroinflammation cells. And so these astrocytes basically line the blood vessel walls that enter the brain. And this is what forms the blood-brain barrier. There's tight junctions, and basically anything that wants to get through usually needs a transporter, almost like an access through the gate, right? We also know that this process is partly important for regulating brain energy metabolism. So if one part of the brain needs more energy, more blood flow goes to that area, and then it helps get more glucose to that system. So this coupling of energy metabolism occurs because of this system. And coincidentally, or kind of on the other end of this, that also is what makes it difficult to get drugs to the brain, right? When this we have to cross this blood-brain barrier, we have to find ways to get drugs to the brain. But you could kind of think of, so we know that the blood-brain barrier breaks down as we age. That's part of the aging process. But that's accelerated in neurodegenerative diseases, so things like Alzheimer's and vascular dementia and Lewy body dementia. And so we get this breakdown. And so these astrocytes, one, they get distracted because they're actively, targeting these pathologies. And they also become, you could think of them as becoming lazy. They look a little bit more like this guy, patting people down, trying to get into the brain. And so these inflammation cells all of a sudden get easier access to the microbes and viruses. Basically anything that's systemically going on all of a sudden has easier access. And this is one hypothesis why, a routine urinary tract infection can cause delirium in patients with dementia. We're going to shift back to risk factors for delirium. So this is a pretty good systemic review. There's so many, there's so many factors. There's like 112 precipitating factors with 33 predisposing factors. I won't go through all those, but I think with what I've told you so far, you could readily guess what the top three are, right? It's advanced age, it's prior history of delirium, and it's a history of cognitive impairment. And one of the reasons why we push so much for early diagnosis is because oftentimes I get consulted in the hospital for someone with no known cognitive impairment, now with delirium. And it's either a known or unknown history of cognitive impairment, right? But sometimes that's sort of the unmasking event that we see. We know that duration of operation, depth of sedation, the sort of intraoperative hemodynamic instabilities are risks. History of anticholinergic or sedative medication use even prior to hospitalization is a risk. Hypoxia and obstructive sleep apnea, metabolic abnormalities, and then obviously what we kind of just talked about, this sort of any sort of neuroinflammation or systemic inflammation. So when someone does have delirium, what do we do? Well, part of it kind of depends on what's causing it. So I kind of think I've dubbed our neurology consult service sometimes because half of our consults end up being delirium. It's sort of like the delirium onion peeling surface, where you're trying to get to the center of the problem, peeling away the different layers. And so we get consulted a lot on something as simple as cefepime toxicity. So that usually occurs in the setting of someone that is on cefepime treating an infection. So they already had a reason to be delirious with the infection. And then if they're older age, they've got prior blood-brain barrier dysfunction. That seems to be one of the mechanisms for why you get cefepime toxicity. So that can occur. We see hepatic encephalopathy. We look for elevated ammonia. On exam, we look for asterixis, and the treatment is much different, obviously, for that. We treat the underlying infection, but this is one thing I really want to highlight. I should bold this. Recognize that delirium may be your clue that an infection is going on. So I really like Dr. Oldham from Rochester. He's a consultant psychiatrist there that really specializes in delirium, and I've learned a lot from him. So he has all these excellent memes. And so here's one that, we always say, don't treat asymptomatic bacteriuria, including in patients with delirium who can't reliably report symptoms, right? And then sort of rethink that equation, right? So if you've got a patient where you don't really have any other cause of delirium, they've got bacteria in the urine and you've at least got reasonable suspicion, then treat it, right? They're not going to report to you that they're having pain or burning with urination. Polypharmacy wise, really think of anything that's anticholinergic. You think of opioids, benzodiazepines. There's a lot of different contributors to polypharmacy, but sometimes it's as simple as the patient's donepezil was held on admission. So restarting those things can be important. When things are really acute, there needs to be some sort of mechanisms to help, right? And so really the non-pharmacologic treatments are by far and away the most effective in delirium treatment. So if family can be there to reorient the patient, a familiar face, right? Getting out of the environment that's causing the problem, going for a walk, even if it's in a wheelchair, just getting out of there can sometimes be helpful. Regulating the sleep-wake cycles, so scheduling melatonin, considering trazodone if high risk. A lot of times patients are dehydrated. If they're delirious, they might not be intaking enough water, so making sure they're hydrated. Assessing for and treating pain. This is especially important in patients that have baseline dementia. They may not be able to report that they're in pain, right? But then knowing that, I should really be careful with opioids because that could provoke delirium or worsen it. So utilizing the non-opioid pain regimens. But then, there's always going to be patients that are just really aggressive and they need something right now. We actually have this in all of the pre-order order sets for surgical patients, right? Haloperidol is on that list. And if I just told you that there seems to be this link, or at least this risk of Lewy body dementia and delirium, how much sense does it make for us to have haloperidol on that list? Because that is a major morbidity risk factor for patients with DLB. So, it's something that I would strongly reconsider if I had any control over the order sets for our surgical patients. And I like this quote from Dr. Oldham: delirium isn't an antipsychotic deficiency syndrome, right? You aren't treating any of the underlying cause there. We generally prefer things like Seroquel as far as an atypical antipsychotic, especially for Lewy body patients, because it doesn't have the strong dopamine blocking portion. And then you'll see our psychiatry colleagues, and I agree with this, recommend low doses of trazodone. And that seems to be much better for the anxiety-driven behaviors too. Even prescribing it sort of before sundowning behavior can be helpful as well. Sometimes we need IV meds though. They're just going to spit out the pills. There's no oral access. There's not great IV med options. Oftentimes we give benzodiazepines, but we know that can prolong and worsen delirium actually. Sometimes that's just needed to calm the patient down, to buy time, and then maybe to start better medications, treat the underlying cause, at least find out what the underlying cause is. So that's a double-edged sword though with benzodiazepines. There's been some suggestions, should we be giving pro-cholinergic medications? So why is that a suggestion? I mean, that's been back and forth. People have discussed since the 1990s. This cholinergic hypothesis makes sense though when you think about what does acetylcholine do in the brain. It's an important neurotransmitter for attention, for focus, for working memory. It's explicitly involved in fluctuations in cognitive symptoms. So these sort of hour-to-hour fluctuations we see in Lewy body disease. We see benefit on visual hallucinations and misidentification syndromes in patients with Lewy body disease when we give them medications that are boosting acetylcholine. And we know that these neurons, specifically the nucleus basalis minor, which is a large projecting region of acetylcholine to the brain, these are intricately involved in Alzheimer's disease and Lewy body disease. And so that's why when you're deficient in acetylcholine, we at least want to try to keep it around longer. That's what these drugs do that are blocking the breakdown of this chemical. So one paper here in 2023 just kind of reintroduced the idea of, should we be thinking of cholinesterase inhibitors as a preventive and treatment option for delirium in high-risk populations? Others have looked at this. I looked at a lot of studies here, kind of getting myself caught up on the literature. There's a lot of mixed results. There was one study in 2004 that actually had to be stopped because there was increased risk of death on the rivastigmine group. But I'll tell you, that was not a good study. And part of this is because delirium is so heterogeneous. Just applying acetylcholinesterase inhibitors to everyone probably doesn't make sense. If you really focus down on patients that might have cognitive impairment, those that would be more likely to be acetylcholine deficient, those that were on a rivastigmine patch postoperative, so this was a 31 placebo, 31 rivastigmine patch group, they had a much reduced odds ratio for postoperative delirium at 0.25. And then in a larger study, this was out of the Northeast. This basically looked at donepezil treatment, having that on board for dementia patients prior to critical illness, and there was overall reduction in delirium and better outcomes because of this. And so what if we were really focused on those that are highest risk? When I talk about this prodromal dementia with Lewy body state, these sort of mild cognitive impairment stages, there's been studies that have looked at the cholinergic system with an acetylcholine PET scan. You can do a cholinergic PET scan, and patients with just REM sleep behavior disorder already have deficiencies in their cholinergic system, so they're at higher risk, right? If you look at the other side of the coin, if you give patients anticholinergic medications, they're at much higher risk of delirium, so especially in those that are high risk in our elderly patients. So, and this really scales with the amount of anticholinergic activity that's detected, where if you've got high activity, then really high risk of delirium. And then a more recent study a longitudinal observational study found that it was about a 4.09 odds risk of delirium for those that were in the high exposure anticholinergic group, and sedative medications. They included that as well compared to the no exposure group. So acetylcholinergics are bad, right? And it's at least something that we have to think about in the high risk population, right? We have to relook at some of those risk benefits of these medications. We can look at this. It's a similar story, not just with delirium, but with dementia. So anticholinergic burden, so both the cumulative use, which is duration of use, and the overall anticholinergic burden are associated with lower cognitive scores and increased risk of dementia across multiple studies. And we see links with increased brain atrophy on brain imaging studies, as well as specifically attention, episodic memory, and executive function difficulties. So what are the biggest offenders? You can do, there's like simple websites. You can just put in your patient's medication list, or if you're a patient or caregiver, you can put in your list of medications, and you can take a look at what is my anticholinergic burden score. None of these things are perfect. There's a little bit different scales with each one. But if you've got like a score over 3, then that's usually clinically significant. And then obviously if you got a score of 9, that's even more significant. Just a score of 3 can be just having one of these high potency anticholinergics on board. So, you know, these are common medications: hydroxyzine or Atarax, oxybutynin, paroxetine, things like amitriptyline or nortriptyline, oxybutynin being a common one, right? Moderate potency ones, it's a little bit shorter list, but cyclobenzaprine and any muscle relaxer basically falls under this moderate group. And then there's a much longer list for the minor offenders. But obviously, if you're on like 10 of these, then that starts to add up, right, from your cholinergic burden as well. Despite some of these recommendations, and there's been multiple studies looking specifically at oxybutynin showing that it has worse cognitive outcomes compared to like something that doesn't, you know, like a beta-3 agonist. But oxybutynin rates have continued to increase over time. Now, the percentage of those prescriptions has decreased, meaning we see an increased prescription rate of beta-3 agonists. It's 24 times higher, but overall OAB, which is overactive bladder, diagnoses and treatment have gone up. So we're still getting a large amount of oxybutynin usage, right? And I use this meme because I know the problem here is cost and access. It's the main barrier. So oftentimes you're having to do prior authorizations, and oxybutynin is so cheap, right? And so it's an easy option. We're at least not at a point where, so the UK actually had a proposal to make oxybutynin over the counter, and luckily that was struck down. But you can imagine what the rates of referrals to my clinic would be if that was over the counter. All right, so I'm going to shift gears a little bit. We're going to talk about COVID-19, but just infections in general. How can that relate to both delirium and dementia risk? So we know that patients with severe COVID-19 had a very high rate of delirium. So it's somewhere around 55%, lasting up to 3 days. So these are folks that are like in the ICU, right, with severe COVID-19. And that delirium was associated with, so if you had delirium, it's a 3-fold increased risk of mortality, again, highlighting why delirium is so important to recognize and try to reduce. What were some of those risk factors? Well, if you had somebody in restraints, or if you gave somebody benzodiazepines or opiates or antipsychotics, the next day they were at a much higher risk for delirium. Was there an associated reduced risk? It was actually if patients had family visitation opportunities. So, you know, in COVID, we had a lot of restrictions of social isolation. Family members couldn't come in, right? But even just virtual visitations was helpful. And this was a dramatic P value here, right? As far as what does that reduce risk? We see this in our cohort participants that have been doing well for many years, participating in, you know, their exercise regimens and their volunteering and staying cognitively and socially active, engaged in group, you know, and then all of a sudden all that was taken away. And so we think that a lot of this social isolation was also a driver of cognitive worsening in the pandemic as well. And then delirium can just be the presenting symptom, just like I told you earlier with UTIs. That can be a presenting symptom of COVID-19 in patients with underlying dementia. And then there's an explosion of reports of some to call it kind of long COVID, or you can call it post-COVID neurologic syndrome, a lot of different terms for this, but a study looking at a lot of patients, these symptoms are quite high 3 months post-infection, of fatigue, brain fog being the one most applicable to our talk today, sleep disturbance being applicable, memory impairment, anxiety, attention disorders. In a certain population, that's just kind of post-COVID infection, and hopefully that will resolve. It usually starts to wane after 6 months, and then ideally after 12 months. But for patients where it's persisting, especially in patients that are high risk in our 65 plus group, how much of this is a cognitive stress test, right? How much of this is a stress test to maybe a vulnerable system, right? We don't know. That's an outstanding question right now. There's been a recent study published looking at overall virus exposures and risk of neurodegenerative diseases. So this was basically, they used 2 national databases, one as a discovery data set in Finland, and then as a replication data set in the UK. It's a large study, so 35,000 people with neurodegenerative diseases versus 300,000 controls. And then they basically looked at viral exposure, and then kind of looked at that viral exposure, how far, before a diagnosis of a neurodegenerative disease was made, and what was that risk. One thing that was nice is there was a study last year that implicated and sort of really showed that Epstein-Barr virus, or EBV, is associated with multiple sclerosis. This study replicated that. And then they found basically 22 viral exposures that were consistent in both data sets, that had increased risks with these different neurodegenerative diseases: Parkinson's disease, Alzheimer's disease, ALS. One of the ones that stood out to me is just influenza and pneumonia. So 1 year prior to AD diagnosis specifically, the hazard ratio was 23 here if they had had exposure to influenza and pneumonia. And then even up to 5 years prior, the hazard ratio was quite elevated. It was closer to 1.5 or 2 if you looked 15 years out. So less link there. But these, there's a lot of remaining questions. This is a nice study showing that, hey, we need to study this more. But are patients with underlying neurodegenerative diseases just more susceptible to severe infections? Because these are obviously cases that are brought to a physician, either the hospital. They've literally had a test, diagnosing them with influenza or pneumonia. They've seen a doctor for this, so it's likely more severe infections. We know this with the COVID-19 data, that patients that have an underlying neurodegenerative disease, especially with dementia, had a much more higher rate of severe infections. And so, it's reasonable to suspect that there might be a link here. And then on the other end of that, does neuroinflammation accelerate underlying neurodegenerative pathology that might already be present? And so when we think of dementia as a multiple hit hypothesis, this is where amyloid plaques are developing for years before symptoms. We see this in alpha-synuclein disorders, where prodromal symptoms are accumulating for years before a clear diagnosis. If we follow genetic cases, part of research studies where we're doing longitudinal imaging, we can see changes in brain networks 5 to 20 years before symptoms. And so is the presence of these pathologies, right, one hit to the, that's the initial hit to the system. We know that basically astrogliosis starts to occur. We get these activated astrocytes to these pathologies. We get neuroinflammation occurring. Then we have a disrupted blood-brain barrier, and that's a vulnerable system that then gets it gets stress tested with certain things like infections, anesthesia, traumatic brain injury, other stressors to the system. And in someone that does have that lowered cognitive reserve, they can't deal with that quite as well. And to kind of tie delirium back in here, that can just be sort of a canary in the coal mine warning that this system is vulnerable, right? Especially in a at-risk population like 65 plus. The last 3 slides here, just to talk about, can we do things to prevent delirium? There's probably I think I saw 3 or 4 different bundles out there, one being this HELP or Hospital Elder Life Program. So if people are following this, or if hospitals are following these types of algorithms, then they can reduce delirium by quite a bit, reducing the rate of falls, and overall saving the health system cost of long-term care costs in the next year following a delirium episode. And then some of the things that these things incorporate. So family members being involved, familiar photos and belongings being around in the room, some things that help with reorientation in an unfamiliar environment. Daytime stimulation, therapeutic activities programs, including working with therapy. Early mobilization, minimizing restraints is a common theme. Sleep protocols, so noise reduction strategies, reduced nighttime interruptions, melatonin or trazodone in even higher risk patients. There's a lot of link of just if somebody needs visual aids or hearing aids, if they get that sensory deprivation, that can be a trigger for delirium worsening. Hydration is a big one. And then one of my hobby horses here is the fact that we see sometimes acetylcholinesterase medications kind of put in that, not necessary group of medicines to make sure we start right away. If somebody's got NG tube access, you can crush donepezil. If you don't have NG tube access, you can use a rivastigmine patch. And so maintaining that acetylcholine issue is important for these patients. All right, so I know this was a longer talk. I'll stay a little bit extra. It's common, delirium is. It's especially important for our patients with dementia, because that it can be very hard to differentiate the two for patients that have underlying dementia. And, it's preventable in many cases. And there's severe consequences for post-delirium as far as mortality risk and a lot of other risks for worsening cognition and dementia. Delirium has many roads that lead to brain network dysfunction, and brains that already have frayed wires and networks are at higher risk for delirium. And there seems to be this link of viral infections probably related to a worsening underlying brain pathology, but there's a lot for us to learn. And I think really studying COVID long-term is going to give us a lot of information with how prevalent it is. So, all right, I will stop there. I'm happy to take some questions. First, check the chat here. Yeah, so Dr. Reddig, you asked a question. Do the bundles to reduce delirium, have they looked to see if they reduce dementia? So yeah, I mean, that is essentially what we're trying to accomplish, right? So, I mean, I think you can sort of connect the dots that if we reduce delirium, and we know that delirium episodes increase the risk of dementia, I think we can connect the dots there, but we'd have to have more longitudinal studies looking at longer term outcomes probably. But that's an excellent thought there. Other questions? I know we've got some members of our cognitive care network team on, and so they get a lot of questions from family, like what should I be looking out for? And in any of these dementia syndromes, we don't anticipate a sudden change like in an hour or in a day, right? That's usually a warning that there's an underlying infection going on. So that's usually where we say, contact your primary care doc, make sure that a urinary tract infection is ruled out, make sure that underlying electrolyte abnormalities and infection are ruled out, because those are the most likely causes of an acute neurologic change in somebody with dementia. I don't know if anyone else from the cognitive care team wanted to chime in on that. I know that you guys get asked about it a lot. So no takers there. Any other questions? Becky mentioned this is scary. Yeah, delirium's a serious issue, and I don't think so. I read a book from 1980 that really highlighted the importance of delirium recognition and how it might interface with brain dysfunction and dementia risk. And we haven't learned a lot in 40 years. Not enough attention has been brought to this, right? And so it's such an important topic. I think we could do so much better. I regularly talk about with my patients as far as, especially elective surgeries, if there's an option for reducing the amount of anesthesia, even considering a spinal block. There was a recent study published just this year that suggested there wasn't a decreased risk of delirium if you went the spinal block route with moderate sedation versus general anesthesia. But I think you'd have to really look at the population that already has cognitive impairment to really answer that question. Because if you include a bunch of people that are at lower risk, then you're going to not have statistically significant numbers there. So there's another proposal out there to do a study that you can do a point of care blood test that measures cholinesterase activity. So, for people that have increased cholinesterase activity, increased breakdown of the cholinergic chemicals, those would be the people that might be higher risk for delirium, right? And so you could think of a study of putting folks on anticholinergic, that'd be like a pre-op test you could do, and that would be your at-risk group, right? Those that have this. So how do anticholinergics increase risk of dementia? So I would think of it exactly the same way we think of Parkinson's disease, right? I think it's a good analogy. So Parkinson's disease patients, they don't present to our clinic with movement symptoms until about 50 to 80% of their dopaminergic neurons have been lost, right? So there's like 50% of the neurons are being lost without clear symptoms until they present to our clinic. If you give them an anti-dopaminergic drug prior to onset of symptoms, they're much higher risk of developing Parkinsonism due to that block. And, so you think of somebody like they have 40% loss of their dopamine cells, then you block the D2 receptors with an anti-dopaminergic, right? All of a sudden they've got Parkinsonism. Is that caused by the drug? Is it caused by they're at risk and you've basically tipped them over into where they look very Parkinsonian? I see that regularly, right? And so the same concept goes with anticholinergics, that if you've got a system that has undergone 40% loss of the cholinergic neurons in that basal nucleus of minor, then all of a sudden you give them an anticholinergic, they're highly susceptible to that because they're at a baseline reduction. Their cognitive reserve to deal with that is very low. And so that follows with, it's my Lewy body patients by far and away that are the most sensitive to these anticholinergics, and they're profoundly efficient in cholinergic systems. And that's why they're also most responsive to procholinergics like donepezil and ribostigmine. Does that make sense if I explain it that way? I guess I would, and this is a simple way to think about it, it's a threshold, right? So like it's a threshold system, and you're tipping someone over through the threshold if they've already are at risk. So anticholinergics does not increase in younger neural. Yeah, like the risk of it. I mean, it's a good question. Probably not. I mean, so like if you are someone that is like that has like a lot of risk reduction factors, genetic and lifestyle, like you're at a really low risk of developing dementia, yeah, the anticholinergics shouldn't have a major effect on you, right? But you're someone that has ApoE4 alleles and other risk factors, and all of a sudden at age 60, all of a sudden you're not tolerating these anticholinergics, and you come see me in the memory clinic because there's some underlying memory issues. I'm looking at that medicine list right away, because that is something that might tip someone over, right? But yeah, it is in the at-risk population that we would think about that. We don't. Yeah, I guess I get what you're asking. I don't think the anticholinergics are driving the disease, right? That from a pathophysiology standpoint, but they are unmasking it. And similar story there with delirium as well. All right. So I have a 1 o'clock meeting I got to get to, but excellent questions, and thank you all for joining. I saw next June 2nd is our next one, so I will see you all then. Have a good week.